Having understood the clinical and microscopic aspects of gingiva, let's understand how these two are connected. The real question is, how does healthy gingiva present clinically, and how do we define what is normal? In this video, we will explore the correlation between the clinical and microscopic features and understand how variations can exist within normal gingiva. Let's start with the most basic yet most important clinical feature, color. We often describe healthy gingiva as coral pink, but in reality, the color of marginal and attached gingiva displays a range from brown, orange to pink, and sometimes even blackish color in some individuals. This variation depends on vascular supply of the tissue, thickness of epithelium, degree of keratinization, and melanin pigmentation. The gingiva also varies when compared to the adjacent alveolar mucosa. The attached gingiva is clearly demarcated from the alveolar mucosa by the mucogingival junction. It appears pale pink and firm due to its thick keratinized epithelium and dense connective tissue, which masks the underlying blood vessels. In contrast, the alveolar mucosa appears red, smooth, and shiny because it is thin, non keratinized, and highly vascular. Another important variation within normal is physiologic pigmentation. This occurs due to the presence of melanin. This is produced by melanocytes within the epithelium. These cells synthesize melanin in melanosomes and transfer it to the surrounding keratinocytes. The extent of pigmentation depends on how much melanin is produced, how actively it is transferred, and how it is degraded. This explains why some individuals show diffuse pigmentation, some shows patches or bands, and some may not show pigmentation at all. Now, one more important point to note is that gingival color often correlates with cutaneous pigmentation. So, in individuals with lighter skin tones, it is usually pale pink or coral pink, whereas in darker skin tones, it may show brown, dark brown, or even blackish pigmentation. This is due to the melanin activity and not a sign of disease. Hence, the color variation is a part of normal gingiva. Apart from color, another important clinical feature of gingiva is its size. The size of the gingiva depends on the overall bulk of the tissue, including its cellular components, mainly fibroblasts, the intercellular components, such as collagen fibers and ground substance, and the vascular component, that is, the blood vessels. Together, these determine the overall volume of the gingiva. In health, this balance is maintained, so the gingiva appears normal in size and well adapted around the tooth. Any change in these components can lead to an alteration in size, which is commonly seen in gingival disease. Moving on from size, let's look at the contour of the gingiva. The contour refers to the overall outline of the gingival margin. In health, the gingiva surrounds the tooth in a collar like fashion and follows a scalloped outline on both the facial and lingual surfaces. This contour varies depending on the shape of the teeth, their alignment in the arch, the location and size of proximal contact areas, and the dimension of the facial and lingual embrasures. In teeth with relatively flat surfaces, the gingival margin may appear more straight, whereas in teeth with pronounced convexity, such as maxillary canines, or in teeth positioned labially, the scalloping becomes more accentuated and the gingiva appears more apically placed. On the other hand, in teeth positioned lingually, the gingiva appears more horizontal and thickened. Now, an important factor influencing this contour is the periodontal phenotype. A thin phenotype is usually associated with slender teeth and a narrow zone of keratinized tissue and appears more delicate and highly scalloped, whereas a thick phenotype is associated with a broader zone of keratinized tissue and appears more dense and less scalloped. Now, coming to shape, this mainly refers to the interdental gingiva or papilla. The shape of the papilla depends on the contour of proximal tooth surfaces and the location and shape of gingival embrasures. When proximal surfaces are relatively flat and teeth are closely placed, the interdental bone is thin and the papilla appears narrow. Whereas when proximal surfaces flare away, the interdental space increases and the papilla becomes more broad. The height and form of the papilla also vary. In the anterior region, it is typically pyramidal, and in the posterior region, it appears more flattened in the buccolingual direction. Now, let's look at the consistency of the gingiva. In health, the gingiva appears firm and resilient, with the attached gingiva firmly bound to the underlying bone, while the free marginal gingiva remains slightly movable. This firmness is mainly due to the presence of dense collagen fibers in the lamina propria, its direct continuity with the periosteum of the alveolar bone, the absence of submucosa in the attached gingiva, and the gingival fiber groups, which help maintaining the firmness and contour of the gingival margin. So, clinically, the firm and resilient nature of gingiva reflects a well organized connective tissue structure. One more important feature of gingiva is its surface texture. In health, the gingiva shows a textured appearance similar to that of an orange peel, and this is referred to as stippling. Stippling is best appreciated when the gingiva is gently dried, and it is mainly seen in the attached gingiva while the marginal gingiva remains smooth. In the interdental papilla, the central portion may show stippling while the marginal borders remain smooth. The pattern and extent of stippling can vary from person to person and even in different areas of the same mouth. It is usually less prominent on lingual surfaces and may even be absent in some individuals while still being considered normal. Microscopically, stippling is due to alternating elevations and depressions on the surface formed by the underlying papillary layer of connective tissue. It is also related to the degree of keratinization, with more keratinization leading to more prominent stippling. So, clinically, stippling is a feature of healthy gingiva and it reflects its structural integrity. Finally, let's look at the position of the gingiva. The position of the gingiva refers to the level at which the gingival margin is attached to the tooth. This position is not fixed but changes during the process of tooth eruption. When a tooth initially erupts, the gingival margin and sulcus are located near the tip of the crown. As eruption progresses, the gingiva appears to shift apically, exposing more of the tooth. This occurs in two phases: active eruption, that is, movement of the tooth towards the occlusal plane, and passive eruption, which is apical migration of the gingiva. So, clinically, an increase in visible tooth structure is mainly due to passive eruption. This also explains the difference between anatomic crown, that is the part covered by the enamel, and clinical crown, that is the part visible in the oral cavity. Throughout this process, the junctional epithelium remodels to maintain a shallow, normal sulcus. So, overall, the position of gingiva is determined by the balance between tooth eruption and gingival adaptation. Slight variation in position may occur with age, but excessive apical shift is considered pathologic. So, when you examine gingiva clinically, you are not observing, you are interpreting the biology beneath the surface. And once normal is clearly understood, recognizing deviations from the health becomes intuitive and precise. And with this, we complete our discussion on gingiva. In the next video, we'll move on to the periodontal ligament, an important 9 marker for BDS final year. Thanks for watching. Follow and subscribe to Gumodont for more simplified periodontics.